Hello everyone, I'm Ambrus Szemere and my thesis is the relationship between sedation, sleep and post-intensive care unit outcomes in critically ill children. I work at the Department of Anesthesiology and Intensive Therapy and at the second Department of Pediatrics. I'd like to improve the quality of pediatric critical care with universally implemented protocolized strategies, and I want to contribute to the creation and implementation of clinical guidelines during my practice. To achieve my mission, I'm currently working on these three specific topics. The first one is the effectiveness and safety of protocolized sedation in the pediatric intensive care unit, which is a meta-analysis. We are almost finished with the first version of the manuscript draft. We plan to finalize it by the end of June and send it to JAMA Pediatrics. We are interested in this topic because sedation practice needs to be improved in the PIC. About half of ICU admitted children are ineffectively sedated, which is a major challenge because both under and over sedation can lead to adverse events, which can prolong the duration of sedation, which will prolong the duration of ventilation and lead to further adverse events and can compromise recovery and will increase the risk of mortality. Protocolized sedation strategies has shown reduced time of ventilation in adult studies, so we aim to compare protocolized sedation to usual care in critically ill children. Here you can see my PICO. We hypothesized that protocol-directed sedation is superior. We defined this strategy when the assessment and modification of sedation levels in individual patients were done based on a predefined algorithm, and we were primarily interested in the duration of mechanically assisted breathing and secondarily the length of stay, the incidence of adverse events, the sedative and opioid exposure, and the incidence of adverse events and mortality. We done this comprehensive literature search in these 5 medical databases with this search key, and we've finalized the selection with 18 eligible articles in the quantitative synthesis comparing protocol-directed sedation management to conventional sedation management. We are primarily interested in the duration of mechanical ventilation. We pulled data together and calculated a mean difference of 6.5 hours, which did not reach statistical significance. And we can see that we assessed a moderate level of heterogeneity which remained after excluding non-randomized studies, which suggested that beside the methodological differences, the different baseline characteristics and clinical settings also contributed to the degree of statistical heterogeneity. We assessed unclear or serious risk of bias for a few domains, and we assessed the whole quality of evidence as low. Secondarily, we were interested in the length of ICU admission, and we calculated a mean difference of approximately 14 hours, and we've seen a high level of statistical heterogeneity, mainly caused by the different ICU discharge policies in the included studies. We also assessed the overall quality of the evidence as low, and we found unclear or high risk of bias in a few domains. Moreover, we were interested in the length of hospital stay, which was also 1 day shorter but did not reach statistical significance, and we've reported a high degree of statistical heterogeneity, mainly caused by different clinical settings and the different population. We put together mixed surgical and medical ICUs in this forest plot. Additionally, we were interested in the safety of this intervention, and we've reported no significant difference regarding the incidence of self-extubations or extubation failure or clinically significant withdrawal syndrome, and we did not report significance in mortality. Moreover, we were interested in the sedative and opioid analgesic exposure, and we've seen a trend in sedation minimization, but the duration of sedation, the IV benzodiazepines and opioids did not reach statistical significance. nor the cumulative doses of opioids and benzodiazepines were statistically significant. However, this intervention could reduce the peak doses of sedatives and opioids without increasing the rate of adverse events. So in summary, we conducted the first meta-analysis investigating protocolized sedation strategies, and we could include 18 eligible studies with almost 14,000 patients. We are up to date. Many studies are very recent, which could be included in our analysis, but we put together studies with different methodology, and in some studies we recalculated non-normal, probably skewed data to means and standard deviations, and also we've come with a high degree of statistical heterogeneity, and we assumed unclear or high risk of bias in a few domains, and we found low quality of evidence regarding our main outcomes. In conclusion, we could not fully support the clinical benefits of this intervention, and we reported a few conflicting results regarding some outcomes and a high degree of statistical heterogeneity, which limits the interpretation of our results. So we can say that protocolized sedation is a safe sedation minimization strategy, but in further studies, they should conduct a sound methodology, high-quality randomized controlled trial with standardized assessment of sedatives and opioids, mainly focused on patient outcomes in different clinical settings. And with the standardized measurement of sedatives, we could see a more clear picture regarding the effectiveness of this intervention. My second topic is the disruption of circadian rhythm in the pediatric intensive care unit measured with actigraphy and its relationship with psychological outcomes. Both are observational studies. We are interested in this topic because there are many factors that could disrupt sleep in critically ill children, and the sleep-wake cycle is crucial in these children to maintain an adequate immunologic response, and its disturbance can compromise physical and psychological recovery. So we aim to measure the risk factors, the development, the progression, and the long-term outcomes of circadian cycle disruption. Here you can see my PICO. We are primarily interested in the objective measurement of sleep with actigraphy, and we hypothesized that ICU admission, sedation, and mechanically assisted breathing can have a disturbance, can disrupt the sleep of these patients. And we plan to determine the modifiable risk factors and the psychological impact of the disruption of sleep in these critically ill patients. First, after the eligibility screen, we enroll patients from an ICU and from a hospital ward. We measure sleep with actigraphy, and we measure environmental factors such as light and noise pollution and the exposure to sedatives and major analgesics. And after ICU discharge, in the follow-up phase, we measure the psychological impact of ICU admission and sleep disruption with questionnaires. It's an ongoing trial. We currently enrolled more than 15 patients, and by the end of the year, we plan to finalize the clinical trial. So in this summary, you can see all my ongoing projects, and I'd like to thank you for your attention. If you have any questions, please feel free to ask them.
Thank you for the presentation. My question is about your first project with your sedative and opioid exposure outcomes.
Yeah.
So you're saying that you're showing there is a tendency to administer fewer grams of sedatives and opioids to children, which is great. And this is saying a lot about over-sedation. But this is not saying anything about under-sedation.
Thank you for the question. It's an excellent question. And we are not really interested anymore after conducting these after seeing these results with the under sedation effects, because as you can see, most of our outcomes that could be included in this meta are regarding the under sedation associated adverse events. So under sedation can increase the rate of self-extubation or can lead to a clinically significant withdrawal syndrome, but these studies did not report statistically significant results regarding those outcomes. And we are more interested in the long-term outcomes of ICU admission, but we could not include psychological outcomes in the meta because only one article reported long-term outcomes. But sedation strategies should be more focused on the long-term effects of sedation exposure. That's why we plan to measure it. But most of the studies, most of the sedation protocols included several different types of sedatives and analgesics, and probably that's why we've reported the high degree of statistical heterogeneity and could not observe statistically significant results regarding the cumulative doses of opioids and sedatives.
Thank you for the presentation. It was really nice. I just want to ask whether have you seen any kind of difference between the older studies and the up-to-date studies? Because you highlighted that you already put inside the up-to-date studies as well.
Yeah, thank you for the question. I highlighted this one because one of the major multicentric cluster RCTs with more than 8,000 patients were published last year, and we could include that one. Before that, only one RCT concentrated only pediatric patients regarding these outcomes, and all the other studies were observational studies. So that's why it's an up-to-date, because it's a very large pool and with many results. Yeah.
Okay. Is there any difference between the older and the younger one?
No, the difference is larger regarding the heterogeneity of the population and the intervention that they've used. So basically, the new RCT just confirmed the results of an older RCT, but on a larger pool.